Anxiety disorders. Anxiety is familiar to everyone as an adaptive response to external threat. Normal fear and apprehension are accompanied by increased activity of the sympathetic nervous system in preparation for fight or flight. Anxiety becomes pathological when it is excessive, prolonged or recurrent, and also focused on bodily sensations. Morbid anxiety can be generalized anxiety disorder, episodic, panic disorder, situational, phobias. The distinction between these as follow. GAD, continuous, pervasive, and persistent, free-floating. Panic disorder episodic with intense unpredictable panic attacks lasting up to 30 minutes. Can occur in any situation. Phobias, situation-specific. Generalized anxiety disorder. Etiology and psychopathology. A genetic contribution to generalized anxiety disorder, GAD, has not yet been established. Biology of anxiety. Release of noradrenaline, e.g. biohimbine, increases anxiety. Gamma-aminobutyric acid inhibits anxiety. There may be an underlying anxious personality disorder with long-standing persistent and pervasive feelings of tension, apprehension, and inferiority, along with an intense fear of disapproval and rejection. The precipitating event is generally a threat to the person's security in a relationship or at work, or being given the diagnosis of a serious physical illness. Thus, danger events, i.e. the expectation of loss or deprivation, precede anxiety, whereas depression tends to be preceded by actual loss. Anxiety reactions are more likely to occur where there is lack of social support due to separation, divorce, or bereavement. Some physical disorders and drugs may mimic GAD. Medical disorders and drugs that may cause anxiety. Medical disorders. Hyperthyroidism, hypoglycemia, cardiac dysrhythmia, pheochromocytoma, respiratory dysfunction. Prescribed drugs. Selective serotonin reuptake inhibitors, sympathomimetics. Recreational drugs. Caffeine, amphetamine, cocaine, LSD. Drug withdrawal. Alcohol, benzodiazepines, opiates. Epidemiology. The 6-month prevalence is 2.5 to 6.5%. The Office for Population Censuses and Surveys National Survey of Psychiatric Morbidity found that in the week before they were interviewed, nearly 3% of the population had a GAD and over 7% had a mixed anxiety-depression. More common in females. This might be due to conflict between work and the responsibilities of child care. Rates of neurotic disorders such as anxiety are much commoner in those with lower socioeconomic status. Onset is most common in late adolescence and early adulthood. Clinical presentation. Anxiety states are characterized by a combination of psychological and somatic symptoms. Psychological symptoms. Inappropriate and excessive sense of apprehensiveness and dread that impairs everyday functioning. Excessive fear of loss, illness, death, accidents, losing control, and going insane. Irritability, restlessness, worrying, poor concentration and insomnia. Thoughts of impending personal catastrophe. Somatic symptoms. These arise from autonomic arousal, muscle tension, and hyperventilation. Somatic symptoms of anxiety. Autonomic arousal, palpitations, muscle tremor, sweating, epigastric discomfort, muscle tension, constricting headaches, backache, hyperventilation, paresthesia, headache. dizziness, faintness. Hyperventilation causes a low PCO2 and alkalosis. GAD can affect various systems of the body. Cardiac, tachycardia and palpitations. Pulmonary, hyperventilation, tightness in chest and breathlessness. Gastrointestinal, dry mouth, difficulty in swallowing, butterflies in the stomach, nausea, and frequent bowel motions. Urinary, frequency. Neurological, headache, lightheadedness, paresthesia around mouth and in hands, tremor, and muscle aches. Autonomic, sweating, shakiness, feeling too hot or cold, and erectile impotence. Treatment. Be circumspect with benzodiazepines. Beta blockers might help to reduce tremor. A sedative antidepressant, e.g. trazodone, reduces insomnia. Cognitive behavior therapy is the safest and most effective treatment. Complications. Anxiety disorders are associated with increased mortality due to suicide as well as alcohol and smoking-related disorders. Dependence on benzodiazepines, hypnotics, and alcohol. Prognosis. Good prognostic indicators. A stable premorbid personality. Development of acute symptoms in response to transitory stress. Poor prognostic indicators. Chronic or severe symptoms. Agitation, depersonalization, or conversion symptoms. Suicidal preoccupations. Persistent social and occupational factors. Inadequate social support. NB. Patients with an anxiety disorder might have a concurrent depressive illness, might later develop a depressive illness, might present with somatic rather than psychological symptoms, might have an underlying medical disorder.